Without further ado, I'd like to hand the presentation over to Julia. She's the Director for Quality Improvement for Guidehealth. Julia?
Thank you so much, Wendy. Good afternoon, everyone. As Wendy indicated, I'm Julia Boggs, Director of Quality Improvement here at Guidehealth. And I am very excited to be here today to kind of walk through the ACO measures that are in play for 2024. And with me is our manager of quality improvement here at Guidehealth. So I'm going to have Jenn quickly introduce herself as well.
Hi, everyone. Thanks for joining today. As Julia said, I'm Jenn Barczak, and I am the QI manager for Medicare Advantage, and I will be going through the slides today.
Thanks, Jenn. So we are going to get started. I have a few slides that I'm really just going to go through and level set, and then Jenn is going to walk through all of the measures. So just by way of introduction, Guidehealth, we are a physician-led, value-based care enablement company. We are partnering with PACN this year around their Medicare Shared Savings Program, ACO. And really the top three goals in this partnership is to help PACN improve around quality performance, to really position themselves for eligibility for shared savings. And equally important is preparing for 2025 quality reporting, which is going to look a little different around the CQM reporting. So for 2024, PACN is planning to report the 10 web interface measures where CMS provides a sample population to be reported on. That reporting period launches January 2nd, and there's a 12-week window through the end of March to report on that sample population across those 10 measures. As it stands, there really will be no change in how the practices under PACN ACO data will be collected and reported. So no change that you'll see on your end. And then just wanted to highlight as well, starting in 2024, CMS did offer a transitional reporting method starting this year and going forward, Medicare CQMs. So that sort of answered the concerns that ACOs had around all payer reporting of CQMs. So starting this year and going forward, there is that transitional reporting method. But again, for this year, PACN is reporting only web interface. And then for 2025, and part of the goal in this webinar today is to not only highlight the measures that are in play for this year, but of those measures, which ones are carrying over to that CQM measure set for 2025. So that is the A1C poor control greater than 9 measure, screening for depression and follow-up plan, controlling high blood pressure. Those are the 3 measures that are carrying over to next year. There is a proposed rule for 2025, which includes 5 additional measures to be introduced incrementally, starting in 2025 through 2028. So that's just kind of important to keep in mind. Here is a list of the 10 web interface measures for this year. And we have a few little symbols that are important as well. So I'm just going to kind of walk through each one. So screening for future fall risk is one of the 10 measures for this year. A1C port control greater than 9 is one of the 10 measures for this year. The star indicates that that has also been in play for next year under the CQM reporting. Controlling high blood pressure less than 140/90. That measure again is in play for next year for CQM reporting. Depression remission at 12 months. This is a measure that performance is not pulled into the ACO's quality score. It's essentially a reporting measure only. Breast cancer screening, the P indicated there is this is one of the 2 measures proposed to be pulled into 2025, as well as colorectal cancer screening. That is also in that proposal to pull into the CQM measure set for 2025. There's an influenza immunization measure, tobacco screening and cessation, screening for depression and follow-up. And again, that's one of those measures that is part of the current 3-measure CQM measure set for 2025. And then there's a statin therapy for prevention and treatment of cardiovascular disease. That measure, performance is not pulled into the ACO's quality score. So we just thought it would be important to list out the 10 measures for this year, the 3 that are for sure making up the measure set for 2025, the 2 measures that are proposed to be pulled in to the measure set for 2025, and then the 2 measures that our performance is not pulled into the ACO's quality score. So with that, I am going to hand it off to Jenn, and Jenn is going to walk through all of the nuance relative to each of these measures.
Yes. Thank you, Julia. All right, so we will go ahead and start with Care 2 Falls, screening for future fall risk. Here we are looking for a screening that was done during the measurement year. We are looking for members that were aged 65 and older. There is no specific screening tool required. However, you certainly can use that, like the Get Up and Go or the Morse Fall scale. Any documentation that lists no falls, any issues with gait or balance is all acceptable documentation. So if you have gait normal, that is perfectly acceptable for this measure. To note, this measure can also be completed from a telehealth encounter and can be completed by any clinician. Some strategies to improve is to do the screening at their annual wellness visits or do the screening at their first encounter of that measurement year. And for falls, there is no exclusions to remove these members from the measure. Next slide, please. Next, we will move on to diabetes. This is for hemoglobin A1C poor control greater than 9. So here we are looking for members that were aged 18 to 75. They are looking for the most recent A1C that is greater than 9. So the lower the score, the better for this measure. And this is for during 2024. Point of care labs or send out labs are acceptable. However, if there is no A1C reported in the chart during the measurement year, that is numerator noncompliance. There is no patient-reported test results accepted. So we are looking for the A1C and then the other names that are listed here for that test. Some strategies to improve is to avoid those A1Cs at the end of the year. Doing a point of care A1C if the member comes in for a visit. And if they are seeing a specialist like an endocrinologist, to secure that documentation and pull that into the chart. And then what can remove a member from this measure? If they are 66 or older and living in a SNF or a long-term care facility, If they are 66 or older and have a claim or an encounter of a CMS-approved frailty diagnosis during the measurement period, and also have a dispensed dementia medication that is on the CMS-approved list, or if they do have one claim or encounter of frailty, along with an acute inpatient or a diagnosis of an advanced illness, 2 outpatient visits, an ER visit, or non-acute stays on different dates of service. Next slide, please. Moving on to controlling high blood pressure. Here we are looking for members that are aged 18 to 85 with a diagnosis of essential hypertension, so benign or primary, nothing that has a secondary cause as to why they have controlling high blood pressure. And this is before or continuing into 2024 or during the first 6 months of 2024. We are looking for that most recent blood pressure that is less than 140/90 during the measurement year. Blood pressures taken from an automated blood pressure device at home and reported to the clinician are acceptable as long as it is documented in the chart. Some strategies to improve. If that blood pressure is coming back and is greater than 140/90, to please do a recheck of that blood pressure, as you can use a representative blood pressure of the lowest systolic and diastolic as long as it's done on that same date of service. Another strategy to improve is to encourage members to have a digital blood pressure device at home. To note, there are some situations where blood pressures are not allowed, and that is any blood pressure that was taken from an acute inpatient stay, an ER visit, a same-day diagnostic test, or therapeutic procedure that does require a change in diet or medication. Some examples are listed here as a colonoscopy, if the member is in dialysis, has an infusion, or chemo. And then what does remove a member from this measure? For hypertension only, it is listed that members that are 81 and older with one claim or encounter for frailty can remove them from the measure. Any diagnosis of end-stage renal disease, history of dialysis or renal transplant, and diagnosis of pregnancy will also remove them for the measure. And then along with the other exclusions that were mentioned, if the age requirement of 66 and older in a SNF, diagnosis of the frailty with the approved medication, or the inpatient stay with those requirements. Next slide, please. Depression remission at 12 months. Here we are looking for members that are 12 years and older with a diagnosis of major depression or dysthymia who have reached remission 12 months plus or minus 60 days after the index event. So the index time frame is not the measurement year. It is listed out and we are looking from November 1st of 2022 to October 31st of 2023. This is looking for the first instance of an elevated PHQ-9 that is greater than 9 during this time frame. It does have to be a PHQ-9. Any other tools for screening do not count for this measure. So that first instance of when they had a PHQ-9 greater than 9, we are looking to see if they've reached remission within 12 months, plus or minus 60 days from that event. To reach remission, we are looking for that PHQ-9 with a score less than 5. As noted, as I have said, the screening tool of the PHQ-9 is required. All questions must be answered and scored, along with that interpretation by an MD. What can remove the member from this measure is any diagnosis of bipolar, select personality disorders, schizophrenia, pervasive developed disorders, or emotionally labile diagnosis. Next slide, please. Moving on to breast cancer screening. Here we are looking for women who are aged 40 to 74 years of age who have had one or more mammogram every 24 months within a 3-month grace period. So here we are looking between the dates of October 1st, 2022 to the end of 2024. If they have had a unilateral mastectomy done, a mammogram must be performed on the remaining side. Any biopsies, ultrasounds, or MRIs are not included as screenings for this measure. Strategies to improve. We do recommend trying to schedule those during their annual wellness visit. And what can remove a member from this measure? If they've had a bilateral mastectomy, and then the following exclusions that we've listed on the previous slides. Next slide, please. Moving on to colorectal cancer screening. Here we are looking for members that are aged 45 to 75. There's a number of screenings that can be performed for this measure. So we are looking for an FOBT during the measurement year, a FlexSig during 2024 or those 4 years prior, a colonoscopy done during 2024 or the 9 years prior, a CT colonography during 2024 or 4 years prior, and a Cologuard during 2024 or the 2 years prior. Just as mentioned with the breast cancer screening, as a strategy to improve, we do recommend trying to get those scheduled during the member's annual wellness visit. And what can remove a member from this measure is any diagnosis or history of a total colectomy or colon cancer that has appropriately been documented in their medical record. And then with the 66 and older, SNF or long-term care with the frailty and the exclusions mentioned before. Next slide, please. Moving on to the influenza immunization. We are looking for 2 qualifying encounters for this inclusion, meaning that the member selected needed to have an encounter done between January 1st to March 31st, 2024, and or October 1st and December 31st of 2024. There are encounters that could have been done during the measurement year, but to qualify for this inclusion, it does need to be done during those 2 timeframes. They're looking for an immunization that was done between August 2023 to March 2024 and August to December of this measurement year. The flu vaccine can be patient reported, and it also can be documented as a refusal. But if the member does refuse the flu vaccine, it must be documented during the current qualifying encounter. Simply entering it at the beginning of the year that the patient refuses the flu vaccine will not count for each qualifying encounter. It does need to be listed for each time. Strategies to improve is really to encourage the upcoming flu vaccine from August to December of 2024. And again, just to remember to document that patient refusal during each flu season. What can remove members from this measure? Any documentation of anaphylaxis or any medical reason, such as an allergy, a patient reason that they have declined, or a system reason that the vaccine is not available at their time of visit. Next slide, please. Moving on to tobacco use. This is screening and cessation intervention for 2024. First, we are looking for members that are aged 12 or older who were screened for tobacco use and identified as being a tobacco user during 2024. The members that were identified as being a tobacco user, we are looking for those members who were given cessation during the measurement period or 6 months prior to 2024. This is including any type of products made or derived from tobacco, with some examples listed below. Strategies to improve is to perform this at their annual wellness visit, and there is no exclusion for this measure. Next slide, please. Moving on to screening for depression and follow-up plan. Here we are looking for members aged 12 and older who were screened for depression using an appropriate standardized tool on date of encounter or 14 days prior, and have a documented follow-up plan if it is positive. That follow-up plan can be documented up to 2 days later. However, the follow-up plan does need to be a referral to a mental health provider or an RX intervention. For example, if a PHQ-2 was done and it comes back positive, a PHQ-9 being performed does not count as a follow-up plan. The type of screening tool must be documented with the score and the interpretation, or it will not count. And new for 2024, diagnosis of bipolar only removes the member from this measure. Previously, it used to be if they had any diagnosis of depression or bipolar, but for 2024, that has changed. Strategies to improve is to please do a screening at every visit. And what can remove a member from this measure? As noted, a diagnosis of being bipolar. And then also, if the member does refuse to have a screening done, please document that in the chart, or if they are having an urgent medical situation, that will remove the member from the measure. Next slide, please. And moving on to statin therapy for cardiovascular disease. Here we are noting 4 levels of member population. First, we are looking for all patients that have had a history or an active diagnosis of ASCVD, including an ASCVD procedure. And this is at any time, so a history of or an active diagnosis of this. If they don't meet that category, we can move into population 2. Here we are looking for members who are aged 20 to 75 with any previous LDL greater or equal to 190 or have an active diagnosis of familial hypercholesterolemia. So this is at any time if they had a lab greater than 190, this would pull that member into this population. If that is not found, we can move on to population 3. Here we are looking for members who are aged 40 to 75 with a diagnosis of diabetes. And new for 2024, if the member does not meet those first 3 levels of the population, we have number 4, patients 40 to 75 with a 10-year ASCVD risk score of greater or equal to 20%. There are some diagnoses listed here below. So any history of MI, a stable or unstable angina, a stroke, a TIA, those diagnoses do pull them in to that category. And what removes a member from a measure? So if they have an allergy to a statin, or any diagnosed associated muscle symptoms, a diagnosis of ESRD, or end-stage renal, active liver disease, or any documented medical reason for not being prescribed statin therapy. And just to remind you, this measure is not looking for adherence. They are looking to see if the member has been prescribed a statin. And we wanted to include a few slides that just listed some examples of frailty. So here you can see any kind of abnormality with gait, weakness, failure to thrive, that history of falls, even just noting that they're on oxygen, needing to use a cane, home health services, etc., are all examples of frailty coding. And those can be found in the CMS coding documents.
Thank you so much, Jen. Just kind of to wrap things up, this webinar has been recorded. We will get the recording out to all of the participants, including the slide deck that we just walked through. And we have a more robust common code document around these measures that will be included in what's going to be sent out as a follow-up. And then we've listed here the quality leadership here at Guidehealth. We've supported a number of ACOs, really starting back in 2014, supporting them in their quality reporting to CMS. So we have a long history. We've seen the measures change. We've seen the adjustments CMS has made. No change there going into 2025. Things are changing there as well. So if there are any questions that you want to take offline, here is our email. And then we wanted to list for certain your PACN quality partners, Lisa, Janelle, and Tracy. And then we listed a few QPP CMS numbers, websites for any additional insight around the measures. Okay, we do have a question from Cheryl Lynn. What are the CPT codes we need to report?
Sure. So each, at the end of the measures, there are coding documents included with the instructions. And then there are also a larger separate coding document that lists out what codes that they do accept.
I was just going to pull up this slide here. So there's a lot of material on the qpp.cms.gov website. There is a resource library where the measure specs and the coding documents live, but we could also include that material in what's going to get sent out to the attendees today if folks are interested. There's volumes of codes.
Yeah, I think that's the point there is that the CMS website is almost overwhelming in its
Yes.
thoroughness and completeness, and you can get lost
Yeah.
in that. So I think both with the help of the PA Clinical Network quality team, Lisa, Janelle, and Tracy, as well as the coding resources that we have with Guidehealth, that we can help get you to the specific codes you may need in specific situations. It's almost, the question is a great one, but it's almost impossible to answer because there's so many codes that correspond to each one of those 10 measures.
Yes.
In doing that, but we'll help you get there.
Yes, thank you.
Well, if there's nothing else, thank you so much for your time, your attention today. We appreciate it very much. Wendy, I think there was a brief survey to be pushed out.
Yes, before logging totally off, you'll get a brief 3-question survey. Please try and answer those questions before you totally log off. You should see it as you start to log out of the call today. Thank you for your time.
Thank you so much. Appreciate it.